The session will be recorded and posted to the StratX website blog and on social media afterward. So if there's any good information here, I don't know if we're all awake and sharp today and come up with some good pointers for people. They can go back and visit those. And just a disclaimer here, this is an open discussion amongst peers that work in the medical industry. The information discussed here today is in no way meant to be legal advice. We're discussing this openly as a conversation, and everything's very fluid today, and it's changing, and we wanted to, just discuss some of the interesting things we're seeing and where we think it may go. So with that, I'm going to start with a question for you, Wiks. Since most practices are trying to get their feet back on the ground and start seeing patients again, is now the time to worry about compliance?
Okay, well, first of all, I'm a self-professed compliance geek, and so is Mike, my partner and colleague. So there's never, it's always time to think. It's a sort of a continuous circle. Compliance should never not be thought of. Certainly now it's come to the forefront. So you really want to make sure that you're reviewing your policies and procedures. If you don't have them, you should be building them. Make sure you train your employees. People always ask me, they're like, if I do nothing else, well, what are some of just the basics that I should do? And I always say, look, build your manuals, build your policies and procedures, your compliance forms, all kind of the bureaucratic paperwork that goes along with all of this. And you can plug in the blanks. It can be a compliance plan. It can be a HIPAA plan. It can be a ASC accreditation program. It can be emergency ops. Again, it doesn't matter, but build your policies and procedures, train your employees, and make sure you maintain compliance. Typically, we go off what are called the 7 elements of compliance,
right?
When we're doing that. And that's basically saying compliance is never over. You're always auditing, you're always adjusting, you're always building, you're always reassessing. So that's my quick answer.
So recently, we know during the COVID outbreak where they were allowing telehealth visits, and there was an indication that the HIPAA rules would be relaxed so that telehealth visits could be conducted more easily during the pandemic, which makes perfect sense. Do we have any indication as to when they'll tighten those rules back up?
And Jack, just to add to what Wiks just finished saying, I was on a call last night through a CMS webinar where almost the identical question was asked. It was more hospital-driven lecture.
Right.
But the key takeaway was compliance doesn't sleep just because of a pandemic.
Right.
Compliance is always around. You have the OIG, you have CMS, you have the Department of Labor. Their job is to make sure, even during a pandemic, that we're not sleeping on our laurels regarding compliance. Whether it's safety for employees, whether it's fraud, whether it's breaches. We've all seen the increase in just yesterday, the Nightwalker episode happened where there are more breaches in healthcare during this pandemic coming forward. So it's now time to really put your plans into place and follow them. That's why everybody is so diligently put them together and trained their people. Now's the time to activate it. Now's the time to be looking at it and paying attention to your own policies and procedures. But just because there's a pandemic or a crisis doesn't mean compliance goes to sleep and waits till everything is over with.
Good. And Mike, we were talking about a week ago regarding the CMS mandates and the hazard vulnerability assessment, and it's actually quite daunting when I look at it. There's so many items on the list. How can providers bite this off one piece at a time? And if you'd like, I could put it up on the screen for everybody.
Let's do that, but let's talk about that first, because CMS has indicated that there's 17 entities that fall under the mandate of having an emergency operations plan. Physician practices and some other entities are not part of that. But the word on the street is after this pandemic and all the mistakes that were made and all the after action reports are going to be put together, it's going to become forward that everybody should have an emergency operations plan dealing with what vulnerabilities they have for their physical facility, plus their county, plus their state. And one of the reasons we see it getting pushed to even the lower levels is during this pandemic, the smaller practices were kind of left out of the lurch while everybody paid attention to the hospital crisis.
Right.
Now we're trying to get the physician practices and the dental offices and other groups back on their feet and back to work. And as we start doing that, having a proper emergency operation program to work from is vital. And if you want to throw up that HVA, this document is a standard document that I believe everybody should be following, whether it's mandated or not. You should know where your vulnerabilities are, and you should know what it is that you should be thinking about in your area. So I noticed on this HVA, which is a national tool, it's a sheet developed by Kaiser Permanente with a lot of input from the feds and the states. But this one here in natural, I mean, one of the first things you have to do is grade what you're vulnerable to and then pay attention to those. So in most areas, as you can see under avalanche, I normally put 0 there. I don't have many facilities that I work with or spoke to groups that are worried about an avalanche. So that doesn't have to be part of your EOP. But as you go through this, it is important for you to look at the different things that are in there. If you're worried about hurricanes, and you grade that, and if you put your little cursor over that little red tick up in the upper right-hand corner for me, Jack, it even spells out for you what the probability is for that hurricane. So if you just look at the little tick in the right-hand corner above hurricane,
Yeah.
just
Above
put your
hurricane?
yeah, right over here.
Yep.
Just put your cursor over that, and that should bring up for you what it's not doing it. Oh,
No.
that's okay. But you're grading these 0 to 4.
Editing there.
That's okay. There you go. So you're grading all categories. As we all know, if you're on the coast of Florida, North Carolina, South Carolina, Georgia, even up here in the Northeast, and we worry about hurricanes, we're going to grade them. And each one of these grades means something. So if you give hurricane a 3, then you're going to go across the board here and grade it between what's your human impact. Well, up in the Northeast, we really don't have as big of a human impact as we do down in Florida. And the one reason that we exercise and we look at Florida is Florida was the first time that we actually had a storm that was bigger than the state. So when we had a lot of folks evacuating their facility and going from Miami to Fort Lauderdale trying to find refuge, and Fort Lauderdale was wiped out, what does your plan say you do further than 2 miles away? Because we've now learned. And so from that incident, what happened? CMS started changing all their guidelines on November 15th of 2017 to include this HVA, to include policies and procedures, to include things like training and drills to these hazards that you are mostly vulnerable to. So I see this coming in every lecture I sit through and every training I sit through. It's coming. When it's coming to be mandated, no one really knows, because we're still trying to catch our breath from this pandemic. And then now also the social crises that are going on. But everybody should have a plan. And if you go to the next one, let's go over to the one that says human.
But before we go over to human, I mean, and just looking at this, do we need to write a plan? Now, obviously, we need to grade the probability for each of these natural disasters. And you're right, an avalanche is not likely here in New York metropolitan Hudson Valley area. But I guess it's possible if you are in California, I guess mudslide would be equivalent to avalanche, right?
There you go.
But if I fill out the probability and the property impact and the business impact and you know, put a probability score next to all of these, obviously later on we need to put a plan together, an emergency operations plan for each one of these. It just seems so daunting to me that there's so many. Do they need to create a unique one for each type of disaster?
Yes, but my suggestion would be for anybody who does not have a plan, except for maybe their fire plan, which a lot of practices do have or practice too. It's an OSHA mandate, so a lot of people have it part of their OSHA safety program.
Right.
But I would always start with my top 10 hazards. And after filling this out, if I hit the top 10 and I see that mudslides are number one, then I'm going to concentrate on that. I'm going to figure out, I'm going to work with the county, and everything is online. So you can even Google the state of New Hampshire. You can Google the county of Middlesex in Massachusetts, and they will have posted their mitigation and their hazard vulnerability analysis. So you can actually use that as a starting block. And then I would start building my policy based on those top 10. What do we do? Where do we evac to? Where do you want me to congregate? Who takes charge? Who's going to talk to the media? I mean, one of the biggest things that happened with this pandemic was we all remember the nursing home out in Washington State. And instead of practicing their incident command, which is part of a national FEMA program, which means you set up an incident command protocol, you should have a media-driven person. And then that training would be based, and then you would train everybody that if media comes up to you, like what happened in Washington State, you do not want your landscaper talking to the media about what crisis is taking place inside your building. You want the person who has been chosen to deal with the media to be talking to the media, and everybody else should be trained to say, I'm not prepared to talk to you, but please go talk to our media director who's located over there in the parking lot. And that's all part of incident command and having a clear line of communication.
So just to be clear to some of the participants here, obviously we're dealing with medical practices of all different sizes, ambulatory surgical centers, you name it. They may not have professional publicists on staff, but are we saying that we should just have someone dedicated to the message that we want to put out?
Exactly. And when it comes to media relations, but it also comes down to having your policies in place and then train people to them. And like when you talk about it being daunting, it is kind of daunting, but once you get into it, you realize you know a lot of the answers.
Right.
You just have to take the time to start building it. And that's why I would say start with your top 10.
Right.
You should have a hazard vulnerability analysis. ASCs are part of the EOP mandate. Hospitals, long-term care, they're part of the 17 entities. I'm seeing now more and more physician groups looking for an answer to be able to cover themselves regarding something like this pandemic happening again. You talked about telehealth. Telehealth should now be put into your EOP based on what do? What do you activate? Who's in charge of activating telehealth if this happens again? Can you handle telehealth during an emergency like a hurricane? But all that's going to be coming forth with as we see the federal and state governments now, like they did in Florida, and like we learned after, I mean, whoever knew that we'd have a city like Houston get 41 inches of rain in a day or two? That's never happened before. So as this grows and as we see the government and the state starting to put things together, it's going to come. And to me, it's best practice. You should know what you're vulnerable to, and you should always let the staff know that. And that's why if you click on the human one for me, and then we'll leave the topic a little bit, a lot of groups I work with, when they get to the human side of these elements, they never want to sit here and look at active shooter person with a weapon and say, well, that'll never happen here. It's never happened here.
How do you know, right?
Use the what if. What if somebody calls in a bomb scare? What if civil disturbance happens outside my door? I want to know what to do. And as an employee, I feel much more favorable toward management when they talk to me about this stuff. We have a plan in place. I know we've received phone calls from clients thinking about and talking about civil disturbance outside of their practice. Employees not wanting to come back to work, not because of COVID, because they're worried about the crowd out front. What do you want me to do? How do you want me to handle that? That should all be starting to be non-mandated entities.
That's what you're not post-COVID now. I've seen many practices scurrying. Being in the IT side of things, they're frantic when they put them in. They limit mental health very rapidly. But what we notice is many times there's no place at all. And I find that even in communication, chain command, it's a big break that. If you can't go into the practice, who's in charge? And then the first part is everybody's phone number. There's real basics that a lot of practices are not prepared for. They don't have the ability to call their patients to let them know that they're open. during the pandemic, blizzard, hurricane. If a hurricane comes through and knocks out lines, they have no qualifications to let them know they're not going to be open. So communications to me is a big factor in any of this, but clearly in an active shooter environment or a disturbance, which I would have ranked a 1 2 days ago, but now today, any practice in Manhattan or any major city or minor city in the United States today has to rank civil disturbance as a high factor.
Well, that's a good point. And as these come about, I'm just always prepared. I always believe in being prepared. I always, pray for the best and think forward. And that's why I've left technology for the end, you being in the IT world. Most of us are used to doing a security risk assessment.
Right.
We do it now every year. We review it every year to make sure things are still in place. Things have not changed in our world of technology. But the technology piece should not be daunting because you should have it all. You should have your plan for a disaster recovery. You should add telehealth now in it, even if it's baseline right now. Right. Who do we call? Who do we activate if we have to go into full-blown telehealth? What do we? And so as these plans mature, no one is saying, get it all done today. What I'm hearing from all of the group that teaches me is start being proactive when it comes to disasters and hazards and vulnerabilities you're going to find you and your employees and your very valuable patients in the middle of.
Excellent. Excellent.
So that's your HVA. You got to start here. Let's find out where we are and what we need to be thinking about.
Let's talk about employees a little bit. I know right now, even within my own organization, we have 3 primary facilities, mostly in the Northeast and some in the Midwest. And we have employees that are afraid to come back to work. How does having a plan in place make employees feel? Does it make them feel more comfortable? I mean, I know it does, but maybe you can elaborate on that a little bit.
Well, anytime you put a plan together, you should be incorporating your employees with it. They should be giving you input. The plan should be put together based on where they're working or what they're doing. They should be part of the solution, not just spoken to, asked for their opinions, because everybody's opinion counts now. There are no experts in this. We're all learning this, and the famous word is together. And so you might have that employee who knows something that could be very valuable to you about your own practice or your own business. But as I talk and interview a lot of the employees, they are very positive when they know management is speaking to them directly and not trying to hide some of the fumbling that took place. Because once again, I always look at, if you're going to drill to something or you're going to practice something, it is okay to make mistakes, because those mistakes are what we can then fix. But if we don't drill to it, we never know what. Why one of the groups that I was working with is a heavy fire department training organization, and they're now getting groups to teach us how to we're all used to. And let's pull a drill on an avalanche that we worry about. Let's pull a drill on a hurricane or a tornado that comes and flattens our town. What do you want me to do? And I see staff really accepting that. I also see a lot of management sending staff to some of their local town or county emergency response training programs. Whether it be a hurricane, whether it be active shooter, send some of the staff members to some of these trainings in your town or your county. Let them meet these people who are going to come in and save you or help you get through the disaster that you're in. And that quells a lot of the fear. It's also like with your patients. A lot of the patients that I've spoken to as they exit a doctor's office really appreciated the fact that everybody was wearing a mask. Everybody was saying the same thing to the patients. All employees were scripted to be able to clean and let people see that you're taking these actions by cleaning the elevator buttons, cleaning the water fountain if you decided to leave that on that everybody's touching to get a drink. These little things go a long way, even for when the patients are looking at what you're doing inside that facility. That's why I applauded some of the practices that I went and worked with that used yellow tape and wrote 6 feet on it, because it clearly indicated I took the time to measure this to make sure you feel more comfortable inside of our facility. And if you don't think your patients are wanting you to, even if you're a small little practice, to act like some of these big corporations. And if you walk into any bank or you walk into even your Home Depot, they have signs, they have plexiglass, they have everything you need to let you know we're thinking about your safety.
Right.
And I think that goes a long way for employees as well as patients.
I think that's a very good point. And it may not all be compliance related, but it is definitely, communications and relationship with your patients today is critical. And I don't know that there's guidelines or mandates with what you have to communicate with your patients, but having a uniform message to your patients and letting them know that you can see them safely will keep them coming to the practice. I'll give you a personal example. My wife had a colonoscopy scheduled for this week, preventative, and she canceled it because she's not comfortable with the facility or what they're doing or how they're doing it. And because I think it's because they didn't proactively reach out to her and say, we're open, we're allowed to see you, and you should be coming in and getting COVID tested prior. And that'll bring up another topic that I'd like to ask one of our viewers today. Giovanna, are you available to chat for a second? Giovanna, do you have a second?
There she is.
Hi.
Hi. So I have a question for you. I do a little speaking for ASCA, and I know that you run surgical centers and are I'll call you an expert in the field. Something that confused me that was going on during this is there were guidelines and mandates coming out. Obviously, if a surgical center couldn't open is one thing. That's pretty cut and dry. But what about when surgical centers could open? I noticed on the ASCA chat boards is where I was seeing people talking about having patients COVID tested, what they needed to do to prepare their facilities for seeing patients. Where are you getting this information from?
I've been very blessed, Jack. I've spent the last 3 months at home training every single day with whatever training has been available by any entity that's in the healthcare field. It is very particular state by state. ASCA has done a compilation of each state's ruling based on the governor's decisions for restarting elective surgery procedures. So it depends on what state you're in, whether or not you had to discontinue them. At the federal level, yes, you did. At the state level for emergent cases only. And then the CMS defined what emergent cases were. So the regulations are being broached by and addressed by multiple agencies having jurisdiction. So it's been very, very confusing. If centers shut down entirely because they had no ability to substantiate an emergent case, like screening, confusion about whose regulations we were going to follow and what state was going to allow what. I don't know that I answered your question with clarity you're looking for. If you mentioned a particular state, I can give you some state regulations.
No, I appreciate that very much. I think it comes back to your plan. Like if clearly governors are making decisions now during the pandemic, I think in someone's plan, in a communication plan, you almost need a where you're going to get information plan so that people aren't scurrying around trying to find information during the pandemic when they may not know. And I think your organizations geared to your particular specialty are helpful in this and pointing you in the right direction. But clearly it becomes slightly chaotic. And I think that's what a lot of these plans are trying to reduce is the chaos during a pandemic. But Mike, I have another question for you in regards to the plans, whether or not it's a natural disaster, going back to the screen here, a technological disaster or a human disaster. You mentioned doing fire drills. And when you mean a fire drill, do you mean like a round table type fire drill where we talk this through?
Well, it's interesting you bring that up because we just got CMS's 1135 waiver form for fire. This is when you pull a fire drill, you're congregating people together.
Interesting.
And one thing we don't want to do. So yes, we can do tabletops with staff. We can do during this. Doesn't mean just because we have a waiver doesn't mean you stop doing something. It's you alter it so that you're at least communicating. How do you do a vertical and horizontal move with somebody in a nursing home compared to somebody in an ASC? What do you do during a fire? And it's different in every entity, in every state, in every authority of jurisdiction. you can always reach out to those folks. They're here to help. And one of the things that I learned in the EOP program was 2009, changed again in 2012, and changed again in 2017. And all those changes came about because of events like what we're going through today. There's obviously going to be things that a pandemic, because inside your EOP, you should have had an emergency infectious disease response program, which part of that would have covered pandemic. And so in that pandemic, who are you following? And I like what Giovanna said, because that's what you do. You take the time to do what I've been doing, and that's listening to the people who quote unquote are in the know and staying on top of it, whether it's CDC, WHO, your local hazmat team, your local governors. But you need to stay in touch as somebody who's managing your emergency ops or compliance program with those entities. And then that's what you're going to follow to the best of your ability, and then inserting things that you know are part of your facility. Do you have gases being pumped through your facility? How do you deal with toilets if you lose water? Where do you want patients to use the bathroom? Where do you want staff to go if you lose water? And sometimes we don't think of that. And so this plan, and what I see a lot of the other entities that were mandated to do this, they've actually learned a lot about their practice by putting together a proper emergency ops program. And they were, I don't want to say well-equipped for this pandemic, but they had a plan in place on to go in this. Good?
I hear you now.
You didn't hear me at all, Jack?
You cut out about 30 seconds ago.
No problem.
So rewind yourself 30 seconds to give me an answer. Actually, I'm going to switch gears. I'm going to ask Wiks a question. Maybe he can enlighten us here. Wiks, the lack of available PPE during COVID was eye-opening, to say the least. I know of even level 1 trauma centers here in New York that only had a week's worth supply of masks, which is baffling to me. They should have had these years ago. Certainly, this is simple and obvious and important. How do you see it impacting compliance planning?
Well, I may push that back to Mike again. Mike, I don't know if that would be part of your, because that's really, if you don't have enough PPE and first aid kits and toilet paper and stuff to last for 2 weeks or whatever it is vulnerability, Mike? I don't know.
I mean, part of any good emergency ops plan and plan, you should have a disaster. We have charts. Why not have a disaster kit? And part of every kit should be masks, nitrile. So part of the whole program is, what do you have in your kit? I always provide what I believe should be in the kit, a disaster kit. I'll do a lot of training on active shooter, and I believe in having a disaster kit in case you do get locked down for a day. You get stuck in place for a day. But, you know, like, do you have a place to go to the bathroom while you're locked away in a room? Well, we never want to think we want to braid to that we never have to use it. But during this pandemic, especially my nursing home clients who had a proper disaster kit, it was stuffed with N95 masks. So at least they had a good start going forward. But I believe that a good EOP would have addressed that. You're not keeping 100 masks or 2,000 masks, but really you will know. Like, I'm getting a lot of questions today to do with the patients who show up with a mask. A lot of groups are turning them away. Well, maybe have a couple masks on site that you could give to those patients, revenue for you. I also got a question the other day regarding somebody taking temperature as they're walking patients in through the lobby. And one of the patient's temperature came back high. And the staff member verbally said, "Oh, you can't be seen today. You need to go back to your car. Your temperature is high." And all of a sudden, the 6 other people who were in that line 6 feet apart looked at this patient like they had leprosy. So now, is that a HIPAA breach? Is that not a HIPAA breach? Is that patient who's now walking back to the car feeling slighted?
Sounds like a HIPAA breach to me.
It sounds like we need to talk about it, but you get a call like that, I scratch my head, and I'm like, after 30 years of compliance, that's a first for me. Well, this whole pandemic is a first for me when it comes to dealing with the patient in line when the temperature is 104 degrees. That employee should have been trained better.
So let's say everybody starts to put their emergency operations plan together, and as we discussed, you can chip away at it. You don't have to get it all done immediately. you kind of build it, and if you build for active shooter, a lot of that may, you know, relate to civil disturbance per se. And if you build for a blizzard, that may also pertain to, you know, an avalanche or, God forbid, a dam failure.
Well, look what happened to our friends in Michigan. I
Yeah.
mean, we can laugh at that dam failure, but I studied that. And a lot of folks laugh at dam failure because they're like, what are they asking me this for? Well, if anybody had pulled their county or their state mitigation plan, they would have seen that dam was on the Federal Register for one of the worst dams in the country. And yes, if I had had a practice or a nursing home or an ASC that was within a mile of that dam, I would have thought twice about that. And I would have had a plan together if that dam does break, which it did. And what did it let loose? You know, 2 billion cubic feet of water.
Yeah.
So, you know, and that may never happen again. Point being is staff and residents and town people all know it and are going to prepare for it better next time.
So in staying prepared and creating emergency operation procedures and doing the hazard vulnerability assessments, how do they manage all of this data? Are we putting it all in books?
Yeah, best. Yes, it should be in a manual that is easily accessible. And I'm going to give you the code is easily accessible by all employees in need. So I have the right, if there's a disaster, to find my manual and use it. Now, I know a lot of people say, well, if there's a disaster, I'm running. Well, sometimes that's not the best thing to do. So manuals are going to be very important. I know most of the 17 entities that were impacted on this in 2017 have written manuals. They have to also update them and review them every year. You also have to update and review your HVA every year. Unless something changes, then you should update it immediately and start working on it. And then you should be drilling to it. Like this pandemic is a perfect drilling exercise that folks should then, when things start calming down a bit, start doing an after action report. What did we do right? What did we do wrong? What could we do better? And then make those plans and build a knowledge base of training around those plans and get your staff involved with it because they can help you out tremendously with this. Plus, a lot of this is also free online. No one wants to hide policy and procedure and best practice from anybody. That's why I say you can find an HVA from your town or your county right online. Use it, but then also make it completely specific to the building you're in, the street that you're on. But it's all there for us to be able to use. I just find, and you've used the word a lot because you're in the same boat, because you're a business owner, it does seem daunting when we have to then continue our regular business activities. But in times of crisis, it really helps you out. And I've seen it help folks out litigiously. Employees wanting to sue because they felt unsafe and you forced them to work or whatever comes down the road. Having a good written plan in place that you're practicing to and updating is a great security blanket.
Excellent. Excellent. And if anybody has any questions, please put them in the chat. I am looking at the chat and we'll relay them. Now, how can HCN or Healthcare Compliance Network help companies organize all of this? I know a lot of this is free and online, and they certainly can go and look all of this stuff up. But how would HCN help them?
We actually have put together plans that we work with each client on separately. And it always starts with the hazard vulnerability analysis, just like with you in your world with HIPAA with the SRA. We got to start someplace. And the nice thing about giving avalanche a zero, Jack, is because then I'm going to take it out of my manual. It's like I get a call last week about a surveyor in there asking for loss of elevator policy. Well, they weren't asking for the loss of elevator policy. They were wondering why you had a loss of elevator policy in your manual. They had bought a canned manual and didn't strip out all the zeros. So the auditor, the surveyor, was looking at this and saying, well, show me your elevator. And Jack turns and goes, well, we don't have an elevator. And the surveyor said, well, then why do you have a policy on loss of elevator? So anything you give a 0 to in your hazard vulnerability, you don't have to write about. You just want to take it out of your manual, and those are things you don't want to worry about. If you do have an elevator, what do you want to do with somebody who's disabled who can't get up to your second floor suite to see you today? Do you have a plan for that? So it's just thinking about it. And I will share with anybody who's on this call our table of contents to our emergency ops plan, tailored down to physician, ASC, hospital. And I'll share whatever it is that can make somebody's life easier. But once again, assess using your hazard vulnerability, build a plan specific to you, and then keep training your people to that plan.
Put our email addresses up in case anybody wants to email Mike, Wiks, or myself any questions that they may think of. And again, we'd be glad to point you in the right direction. And as Mike said, give you a table of contents. And I know he has programs to further help and assist businesses, practices, and centers in getting this all in place. And while you know, I know I'm using the word daunting. Well, it looks daunting when you read through the list of how many different scenarios there are. Again, much of it is the same, and HCN can help you pull all of this together. And this is not a sales pitch. We're really here today to share that the premise that we're really trying to convey is to get started building the plan, and a lot of it falls into place. And when you have a plan and something goes wrong, you use the plan as an anchor. Obviously, it's not gospel. You're going to deviate from the plan here and there as needed. As Giovanna was expressing before, where she's getting information on what's legal for a surgical center to do today, I don't think you could put that all in a plan. You've got to be on your toes, but she's responsible for doing that. And I think that could be in your plan. Who's responsible for doing what? And who's going to communicate to the employees how this is going to happen. And having those fundamentals in place goes a long way in keeping your employees comfortable and your practice or centers operational.
And Jack, it's a lot more daunting when a crisis happens and you're caught with your pants down than it is to try to build it while you have some, I don't want to say spare time because we're all working 3 clocks today, but
Right.
Point being is it's a lot worse than what happened up at that nursing home in Washington State back in February. They got caught with their pants down, and everybody's at that nursing home. They didn't have a incident program by FEMA, which they should have. And so daunting it is, but I will tell you, everybody I've worked with, once we get into it, they know the answers to all of these. They know what to do in their town during a flood, during a disaster. They know what to do if something happens. They just haven't written about it. That's what they need to start doing. And then taking those written policies that you know and training your staff on it. And it'll go a long way. There's a disaster, litigiousness, staff failure, and favorability.
Excellent. Excellent. All right,
Any
we're at the 45-minute mark, gentlemen. We're going to wrap it up. And I just want to thank everybody again for attending today. Hopefully we can continue to share more information. And Mike and Wiks, thank you very much for your expertise and opinions in all of this. And you know, things are changing day by day. We could probably convene again in 2 weeks and have all new stuff to talk about, unfortunately. But again, our email addresses are up on the screen. Please feel free to email us any questions. We'd be glad to reach back out to anybody and point them in the right direction. And again, the session is recorded. We will edit it and clean it up a little bit and put it up on the StratXIT.com website and social media. So with that, thank you, everybody. And
You
have
all.
a great afternoon.
Thanks, Jack.